Today, in What's New in 22q, we are taking a journey into the body's defense system.
Mm.
You know, when we talk about the immune system, I think most of us have a very specific, sort of limited picture in our heads.
Mm-hmm.
We think about the common cold. We think about flu season, maybe needing antibiotics for a runny nose.
Right. It's the body's defense department.
Exactly. And we usually only notice it when it's failing to do its job. But today, we are going to completely dismantle that metaphor. We are digging into a stack of research regarding 22q11.2 Deletion syndrome that suggests the immune system is doing a lot more than just fighting off the sniffles.
So much more.
We're finding out that in 22q, this system is a massive complex network that connects to the joints, determines how well vaccines actually work, and this is the part that frankly surprised me. It might be directly talking to the brain and influencing behavior.
It is a fascinating web of connections. We're really moving away from the idea of the body as a series of separate compartments. You know, here's the heart, there's the immune system, up there is the brain.
All in their own little boxes.
Exactly. The research we have on the table today, ranging from 2019 all the way up to 2025, really shows that in 22q11.2 Deletion syndrome, or 22q11DS, everything is in constant conversation. And understanding the language of that conversation, specifically the dialect of the immune system, is absolutely key to managing health.
Okay, so before we get lost in that web, I want to set the stage properly for everyone listening. This deep dive is a special episode of What's New in 22q. And it's produced by Dr. Stephan Eliez for 22q11 Europe, the association that is out there every day supporting families and relatives.
Vital resource.
Absolutely. Our mission today is to unpack a fairly massive stack of papers, and we are going global for this one. We have studies from Colombia, Taiwan, France, and the U.S.
It's a truly global perspective, which is so important. 22q11DS doesn't care about borders, but you know, environmental factors can change how it presents. By looking at data from South America, Asia, and Europe, we can start to distinguish what is a universal feature of the deletion and what might be specific to a certain region.
That makes sense.
Yeah, so we're going to look at how the immune system evolves as a child grows, this concept of dysimmunity, which is really different from just having a weak immune system, a rare form of arthritis, and finally, a groundbreaking look at how antibodies might be driving psychiatric symptoms.
So let's start with the baseline. If you are a parent of a young child with 22q, getting sick often is probably the #1 thing you deal with day to day. It's the constant worry.
It really is.
We have a study here from Colombia, published just this year, 2025, that puts some hard numbers to that experience.
Yes, this is a paper titled Immunological and Clinical Characteristics in a Cohort of Colombian Pediatric Patients with 22q11.2 Deletion, published in the journal Immunologic Research. The lead author is Lina M. Castano-Aramillo and her team.
Why is a study from Colombia specifically important? Usually we see these big data sets coming out of, major research hubs in Philadelphia or Geneva.
Diversity is the key. It's so crucial. Most of our historical data is Caucasian, North American, or European. This study looked at 40 children in Colombia, and it helps us confirm if the genetic signal of 22q is strong enough to look the same across different genetic backgrounds and different environments. And in this case, the answer is largely yes. It validates that the challenges families face are, well, they're universal.
They really mapped out the whole clinical picture. What stood out to you in their findings?
They confirmed the classics of the syndrome, which is important for establishing that baseline you mentioned. For instance, congenital heart defects were present in 75% of these children.
Wow, 3/4 of them.
A very high number, but it aligns with what we know about the embryology, the heart and the thymus gland, which, controls the immune system. They develop from the same pharyngeal pouches in the embryo.
Right.
So if one is affected, the other usually is too. It's a sort of developmental package deal.
And regarding the immune system specifically, because that's our focus today.
Well, they found that recurrent infections were a reality for nearly half the cohort, 48%. And we need to be specific about what infection means here. We aren't just talking about a runny nose or a mild cough. The study specifically highlighted recurrent pneumonia and otitis ear infections.
Pneumonia is a heavy burden for a small child. That means hospital visits, antibiotics, a lot of stress for the parents.
It is. It's a huge burden. And recurrent ear infections are more than just painful. They can seriously impact hearing development. If a child has fluid in their ears constantly during those critical toddler years.
Right, when they're learning to talk.
Exactly. It impacts speech development, which is already a vulnerable area in 22q. So preventing these infections isn't just about health in the moment. It's about protecting their long-term developmental potential.
Now, this leads us to what I thought was the most critical practical insight from the Colombian team. They didn't just count the infections. They looked at the body's response to the tools we use to stop them. They looked at vaccines.
This is the real aha moment from this paper. It's so important. Parents often assume that if you get the shot, you are protected. It's a binary thing in our minds. Shot in arm equals safety.
Yeah, you check the box and move on.
But the immune system has to actively participate in that process. It has to read the instruction manual that's contained in the vaccine and then file it away in its memory banks.
And in 22q, that filing system might be a little bit glitchy.
That's a great way to put it. The Colombian study found that the response to vaccines, particularly to Streptococcus pneumonia, that's the specific bacteria responsible for many of those pneumonia and ear infection cases, was frequently impaired.
Impaired.
This is what we call a specific antibody deficiency.
So walk me through that mechanism.
Yeah.
The child gets the pneumococcal vaccine.
Mhm.
What happens inside their body versus a typical body?
Okay, so in a typical body, the immune system sees the vaccine components. Specialized cells called B cells get activated. They turn into memory cells and plasma cells that just pump out antibodies. Think of them as the soldiers designed to kill that specific bug. They produce a high titer, or level of soldiers. In many of these 22q patients, they get the vaccine, but the B cells don't produce enough soldiers, or the memory just doesn't last. The titer is non-protective.
That is incredibly important because it completely changes the strategy. You can't just follow the standard vaccination schedule and assume you're good.
Correct. You can't. It suggests that for these children, checking antibody levels, literally measuring if the vaccine worked, is a necessary step. It's not enough to just check the box that the shot was given.
So you have to follow up.
You have to follow up.
Yeah.
And if it didn't work, they might need boosters or even different formulations of the vaccine to really wake up the immune system.
Okay, so that's the snapshot from Colombia. High infection rates, heart issues, and a specific failure to hold on to vaccine protection. It paints a tough picture for the early years.
It does.
But I want to pivot now to the other side of the world, to Taiwan, because we have another study here that answers the question every parent asks, will this last forever?
This is the longitudinal view we desperately need. This study is by Xunhui Yu and colleagues, titled Clinical and Immunological Defects and Outcomes in Patients with Chromosome 22q11.2 Deletion Syndrome. It was published in the Journal of Clinical Immunology back in 2022.
And longitudinal here means they followed patients over time, right? That's kind of rare in research.
It's very rare and very valuable. Yes, this was a retrospective study of 87 patients over a period of 22 years. They could effectively watch the immune system grow up. They weren't just taking a snapshot, they were watching the whole movie.
So what was the starting point for these kids in Taiwan? Did it match what they saw in Colombia?
Very similar to Colombia, they found that early on, T-cell lymphopenia was very common. About 71.9% of their cohort had it.
Okay, let's define T-cell lymphopenia. We hear low T cells a lot in the 22q community. What does that actually mean for the defense system?
Think of the T cells as the generals and the elite special forces of the immune system. They direct the battle, telling other cells what to do, and they also directly kill infected cells.
They're the quarterbacks.
The quarterbacks, exactly. In 22q, because of the thymic hypoplasia, that's the underdevelopment of the thymus gland, the boot camp where these T cells get trained is too small. So you end up with fewer troops. That's lymphopenia.
So fewer troops equals more infections. The defense line is just thin.
Precisely. But, and here's the major takeaway from the Taiwan data, this state is dynamic. It is not static. They found that severe lymphopenia tends to improve with age.
It fixes itself.
Yeah.
That sounds almost too good to be true.
In many cases, yes. It's really encouraging. They found that by age 3, there was significant improvement. The immune system matures. The T-cell numbers often creep up toward normal ranges, or at least to levels that are functional enough to keep the child healthy.
Why does that happen? Does the thymus grow, or does the body find some kind of workaround?
It's a bit of both. The existing thymus tissue, even if it's small, is very active. But there is also a phenomenon called peripheral expansion, where the T cells that are already out in the blood start to multiply on their own.
Oh, interesting.
The body realizes it's short-staffed and starts recruiting and multiplying from within the existing ranks.
That is a huge relief. So if you were in the trenches with a 2-year-old who has ear infection number 5 this winter, this study suggests it is likely a phase, not a permanent state.
That is the message. The immune deficit in 22q is rarely progressive. It starts rocky, but the trajectory is upward. By preschool or early school age, many of these children have immune profiles that look much, much closer to their peers.
It's a marathon.
It's a marathon, but the hardest part is often the first few miles.
So we have this picture of a rocky start, lots of infections, maybe vaccine issues, but a trajectory that points toward improvement. However, we have to complicate things, because the immune system isn't just about being weak or strong, it's about being regulated.
This brings us to a concept that is so central to understanding 22q11ds but is often overlooked: dysimmunity.
Dysimmunity. It sounds like a system in chaos.
That is exactly what it is. It's not just an immunodeficiency, which means too weak. It's an immune dysregulation, which means confused. We are drawing here from a French study published in 2019 in the American Journal of Medical Genetics Part A. It's by Perrine Mahé and her team, titled Risk Factors of Clinical Dysimmune Manifestations in a Cohort of 86 Children with 22q11.2 Deletion Syndrome.
And they introduced this idea of a triangle. I love visual concepts like this. It helps it stick.
Yes. Picture a triangle. The three corners are infections, allergy, and autoimmunity. The study suggests these three things are deeply interconnected in 22q11ds. You can't just look at one corner without considering the others.
Okay, we've covered infections pretty well. Let's talk about the other two corners. Allergies seem pretty common in the general population. Are they different here?
They are common, but in this cohort, they were present in 27% of the children, so more than a quarter. We're talking asthma, allergic rhinitis, eczema.
The usual suspects.
The usual suspects, yes. But the key finding was the statistical connection. They discovered that having low CD4 plus T cells, those are the helper cells, didn't just predict infections, it was statistically correlated with autoimmunity as well.
Wait, hold on. So the same problem that makes you weak against viruses, the low T cells, also makes you more likely to attack yourself with autoimmunity. That seems completely contradictory. Shouldn't a weak system be less likely to attack?
It seems that way intuitively, doesn't it? But it goes back to the boot camp analogy of the thymus. The thymus has two jobs. Job one is to train T cells to attack germs. Job two is to train T cells not to attack the body.
Okay.
This is called central tolerance. If the boot camp is understaffed or not working right, you get fewer soldiers, which leads to infections, but you also get poorly trained soldiers who might mistake the thyroid or the blood cells for enemies, and that's autoimmunity.
That is a really helpful way to visualize it. Bad training leads to friendly fire.
Exactly. Friendly fire is autoimmunity. And the study explicitly says that a child with a history of severe infections needs to be watched more closely for autoimmunity. It's a red flag. If you see one corner of the triangle, you have to look for the others.
Which leads us perfectly into our next topic. Because one of those friendly fire incidents, one of those autoimmune conditions, can be so easily missed in children. And we have a brand new 2025 study that focuses specifically on it.
This is about chronic arthritis. Now, when we think of arthritis, we usually picture a grandmother with aching knees or maybe an athlete with a bad hip. But in 22q11ds, this is a pediatric issue.
This comes from a paper titled Chronic Arthritis in 22q11 Deletion Syndrome, published in the Orphanet Journal of Rare Diseases just this year, 2025. The lead authors are Emily Leibling and Caroline Freischett. It was a massive international effort, wasn't it?
It was. It had to be. Because this is a rare complication of a rare syndrome, no single hospital sees enough cases to really understand it. So they surveyed pediatric centers internationally and identified 30 patients with both 22q11ds and chronic arthritis.
30 patients. That doesn't sound like a lot in the grand scheme of things. Is that statistically significant?
In the world of rare disease, 30 is a robust cohort. It really is. It's enough to see patterns that you simply cannot see when you just have one patient in your clinic.
Yeah.
It allows us to define the phenotype or what the disease actually looks like so other doctors can recognize it.
And what does it look like? Because I assume a 3-year-old doesn't walk up to mom and say, "Mother, my joints are inflamed."
No, absolutely not, and that is the danger. The median age of onset in this study was just 3 years old.
3 years old? That is incredibly young.
It is, and think about a 3-year-old with 22q. They might already have hypotonia, low muscle tone. They might be a bit clumsy or delayed in walking.
Sure.
If they fall down or don't want to walk, parents often assume it's just the hypotonia or growing pains, or maybe they just bumped their knee on the playground. It's so easy to explain away.
So how do we tell the difference? What did the study identify as the hallmarks?
They described it as often being polyarticular. That means it affects 5 or more joints. It's not just one sore knee. It might be knees, ankles, wrists, and fingers all at once.
Multiple spots.
Multiple spots. And interestingly, there was a strong female predominance. 20 out of the 30 cases were girls.
Okay, so if you have a young daughter with 22q around age 3 or 4, who is stiff in the morning or refusing to use her hands or walk, that is not normal growing pains.
Correct. That's a key point. Growing pains usually happen at night and affect the legs. Inflammatory arthritis is usually worse in the morning. The child wakes up gelled or stiff, and it improves as they move around and warm up. That morning stiffness is a key differentiator.
And is it treatable? Or is this just something they have to live with?
It is very treatable. The study showed that these children responded to the standard rheumatology toolkit, things like steroids, methotrexate, and biologics. They got better, their pain went away, their mobility returned.
That's great news.
But, and this is the crux of it, you can't treat it if you don't diagnose it.
That is the takeaway. Do not dismiss persistent joint pain or stiffness as just part of the syndrome. It might be this autoimmune arthritis.
And connecting it back to the French study, if your child has had a lot of infections and then develops this stiffness, your radar should be way up. It's the triangle again. The immune system is struggling to regulate itself.
We've gone from the heart and lungs with infections to the joints with arthritis. But now, here's where it gets really interesting. We are going to go upstairs to the brain.
This is perhaps the most cutting edge and frankly the most exciting part of our deep dive today. We have two papers from 2025 that are really changing the conversation about psychiatric symptoms in 22q.
Yeah, we know that 22q carries a significant risk for psychiatric issues, including anxiety, ADHD, and more seriously, psychosis and schizophrenia. For a long time, the assumption has been, well, the gene is missing, the brain developed differently, the wiring is permanent. It felt very hardwired.
Right, the broken hardware theory. It's genetic, so it's set in stone. But these new papers suggest there might be a biological immune-driven component that is active, ongoing, and potentially treatable.
Let's look at the first study. This is by Samantha Y. Starkey and her team, published in the Journal of Allergy and Clinical Immunology in 2025. The title is Autoantibodies in Patients with 22q11.2 Deletion Syndrome and Psychosis.
This study asked a simple but really profound question. Do the patients with psychiatric symptoms have a different immune profile than the patients without them?
Okay.
They took a group of adults and kids with 22q. Some had a diagnosis of psychosis, some did not, and they analyzed their blood for autoantibodies.
And what did the blood show?
It showed a clear difference. The patients with psychosis had significantly higher levels of autoantibodies compared to those without psychosis. Specifically, they found antibodies against things like single-stranded DNA and other cellular components.
Okay, pause. What does that mean? The people seeing things or hearing voices, the people with the psychiatric symptoms, had an immune system that was attacking the body's own code.
In a way, yes. It implies that the immune system is more autoreactive in the group with psychosis. It's creating antibodies that target the self. Now, we have to be very careful. Correlation isn't causation.
Right.
Just because the antibodies are there doesn't prove they cause the psychosis. But it suggests a link. It suggests that the immune dysregulation we talked about earlier isn't stopping at the neck.
And that leads us to the second paper, which actually proposes a mechanism for how this might be happening.
Yep.
Because the brain is supposed to be protected, right? Has a firewall.
Exactly. This is a review by Suzanne Ali and Bradley Pierce, accepted for ACTA Neuropsychiatrica, titled The Role of Autoantibodies in the Neuropsychiatric Manifestations of 22q11 Deletion Syndrome. They discuss the blood-brain barrier.
The bouncer of the brain.
The bouncer. That's a perfect description. Normally, the blood-brain barrier, or BBB, is a very strict wall. It keeps the blood and the immune system's soldiers separate from the sensitive brain tissue. It says, you can pass, but you, Mr. Antibody, you stay out. It maintains this pristine environment for the neurons to fire.
But in 22q,
they propose that in 22q11ds, that bouncer might be distracted. The barrier might be leaky.
a leaky barrier. That sounds ominous.
It's a compelling theory. If the barrier is permeable, those autoantibodies we found in the Starkey study, which are just floating around in the blood can, cross over into the brain. Once they are there, they might interact with brain tissue, specifically with receptors like the NMDA receptor.
And the NMDA receptor is crucial for how we perceive reality, isn't it?
It is fundamental for learning, memory, and cognition. If an antibody attaches to it and blocks it or overstimulates it, it's effectively gumming up the works. It causes inflammation or dysfunction that disrupts how the brain processes information. This could manifest as confusion, cognitive decline, or psychosis.
That is mind-blowing. Because if that's true, it changes everything about how we view these symptoms. It moves it from genetics to immunology and inflammation. We can treat that. We have drugs for that.
That is the hope. The authors call it moving from genetics to treatable biology. If a significant portion of the psychiatric symptoms are driven by this autoimmune process, this leaky barrier letting antibodies attack brain tissue, then theoretically, treatments that target the immune system or clear out those antibodies or even seal up that barrier could help the psychiatric symptoms.
We aren't there yet, obviously. We aren't prescribing anti-inflammatories for schizophrenia and 22q just yet.
No, absolutely not. We were very much in the hypothesis stage, but it opens a door. It suggests that if a patient has a sudden onset of severe psychiatric symptoms, a flare, if you will, we shouldn't just look at the psychiatrists. We might need to look at the immunologists, too.
Wow.
We might need to ask, is there an autoimmune storm happening here that is affecting the brain?
It ties everything together. The infections, the autoimmunity, the arthritis, and the brain. It's one system.
It really is. And I think for families, that can be overwhelming. Oh, great, one more thing to worry about. But it can also be incredibly empowering because it means you aren't fighting 5 different wars. You are managing one complex system. If you stabilize the immune system, you might help the joints and the brain.
So let's pivot to that management. We've covered a lot of dense science. We've gone from Colombia to Taiwan to the blood-brain barrier. What does this all mean for a parent listening today? Let's break it down into some practical takeaways based on these papers.
Sure. I think we can distill this into 4 or 5 key action items.
Let's start with the basics. Takeaway number 1, vaccines.
Yes. Based on the Colombian study by Castano Jaramillo, we know the response to vaccines can be weak. The file doesn't always get saved. So for a parent, the recommendation is vigilance. Don't just assume the shot worked because it was given.
So what do?
You can ask your immunologist or pediatrician to check antibody levels. They're called titers, especially for pneumococcus, the pneumonia bacteria, and tetanus.
And if the levels are low?
The doctor might recommend a booster shot. It's a really simple step, but it could prevent those recurrent ear infections and pneumonias that plague the early years. It's all about verifying protection.
Okay, practical tip number 2. The disimmunity radar.
Right. Drawing from the Mahe study from France, we know now that infections, allergy, and autoimmunity form that triangle. So if your child is struggling with one, look for the others.
Connect the dots.
Connect the dots. If they have had constant infections and suddenly develop a strange rash or joint pain or thyroid issues, don't treat it in isolation. Mention the disimmunity risk to your doctor. Ask, could this be autoimmune?
And specifically regarding that joint pain, that's takeaway number 3.
Do not dismiss joint pain in a young child with 22q. The labeling study shows arthritis can start as young as age 3. If they are limping or stiff in the morning or complaining their wrists hurt, ask for a referral to a pediatric rheumatologist.
Don't wait.
Don't wait. It is treatable, but you have to catch it. Don't let someone tell you it's just growing pains or hypotonia without checking. Trust your gut.
And finally, the brain-immune connection. Takeaway number 4.
This is about a holistic view of behavior. Based on the psychosis and antibody papers from Starkey and Ollie and Pierce, if you see a sudden, drastic change in behavior or psychiatric status, it is worth discussing the immune health with the doctor.
Bring it up.
Bring it up. Ask, is there an underlying infection? Is there an autoimmune flare-up happening at the same time? Treating the body might help the brain. It's about looking at the whole patient, not just the symptoms in isolation.
And I think we need a 5th takeaway, which is just hope.
Absolutely. The Taiwan study by you and colleagues is our anchor here. Yes, the T-cell counts are low in the beginning. Yes, the infections are hard in the toddler years. But the data shows a natural improvement. The immune system matures.
It gets better.
The numbers get better. For many, many families, the sick all the time phase is just that, a phase. It is not a life sentence.
That is so important to remember when you are in the thick of it. The body is learning. It's a slow learner, maybe, but he gets there.
It is. The body is resilient, and with the right support, the boosters, the monitoring, the early treatment of autoimmunity, these children can thrive.
This has been such an incredible dive into the mechanics of 22q. It's complex, yes, but the more we understand it, the less scary it gets. It moves from mystery illness to a biological puzzle we can solve.
I agree completely. Knowledge is the best tool these families have. And this research, especially the work coming out in 2025, is giving us sharper tools than we have ever had before.
Well, we are going to wrap it up there. This podcast is brought to you by 22q11 Europe, the European Association supporting families living with 22q11 deletion syndrome. They are doing amazing work connecting the research to the real world.
And a huge thank you to the researchers, Dr. Castano Jaramillo, Dr. Yu, Dr. Mahe, Dr. Liebling, Dr. Starkey, and everyone else pushing this field forward. Their work is truly changing lives.
Thank you for listening to What's New in 22q, produced by Dr. Stephan Eliez for 22q11 Europe. Take care and talk to you soon.
Goodbye.